All right. Hey, folks.
Hey there.
Yeah, it's good to see everyone. So what I would like to do is just to for all of us to introduce ourselves to one another, and then we'll kind of dive right in. Today, our TA Kelsey is gonna drive here a bit more than I am. But it'll be a great discussion all around. For those of you who've never had me before, I'm Dr. McCormick, and I am joining y'all from the beautiful scenic Hocking Hills of Ohio. Rosie, do you want to introduce yourself?
Absolutely. It's nice to meet you all. I don't think I've had the pleasure of your companies before. So I'm a doctoral student here in the program, helping out with the class, and it's exciting to be here. I am also from Ohio, but not from the beautiful scenic part. I'm from the part with lots of cornfields, soybean fields, lots of farming. So not quite as
We,
beautiful, but still Ohio, still has some scenic beauty.
My name is Khaloud. I'm from Egypt. I'm in Cairo right now.
I'll go next. Hi guys, my name is Andrea Good. I'm from Baltimore, a very crazy city. Um, yeah. What else were we supposed to say?
that's
It.
good.
Here, so.
Hi guys, I'm Victor. I'm living in Vietnam, which is 12 hours ahead of Chicago's time. It's 11 p.m. Right now here. Yeah, so it's pretty late where I live now.
Yeah, what city are you in, Victor? I missed it.
Um, I'm living in Vietnam. So it's a country.
Oh,
the
okay.
city I'm living in is Ho Chi Minh City. It's in the
Oh,
south of Vietnam. Yeah.
wow.
Wow.
Look at our international folks today.
Yeah,
Strong.
yeah.
I think it's easier for us to take the earlier classes just because it makes sense with the timings and stuff. That's why.
That does make sense.
It does, for sure. There's a case study for our class discussion or live discussion here today, which I'm sure y'all have looked over already. And so, like I said, we're just gonna kind of talk about this particular case, talk about some specifics with regards to the case, and treatment options and things of that nature, as we sort of walk through and talk about all the various different things and whatnot that we see in this case conceptualization.
So you want me to take over the reins from there, Dr. McCormick, or do you have other things to start with?
No. I think that's as good a place to start as any.
Awesome. So I know that there were some discussion questions that were posed to you all that hopefully you've had a chance to look over and at least think about. Kind of in thinking about today, Dr. McCormick and I want to go through those questions, but also be open to other thoughts or ponderings or questions that come up for you around it. I do have a little bit of information that I want to share with you. So not a presentation necessarily, but for each question, I have a few PowerPoint slides just with some information that I wanted to make sure I share. That's kind of been my role in this class, is to make sure I give you more information, and of course answer questions that you have. So that's our plan for today. Let's see here. I'm going to go ahead with our first question, since I thought you had all read the material. So this week and this discussion is talking about complex trauma and dissociation. And obviously those are things that I think we can see in this case study. So let's go ahead and start with the first question, and we'll start there. But again, it's okay if we go a little bit off the direct topic of the question. I'm going to put it in the chat for those of us who prefer reading as opposed to hearing. So the first question, what are some common symptoms of complex trauma that we see in this case? So free for all discussion. We don't have to raise hands or anything with there being 3 of us, unless you want to.
I think what I noticed is obviously the anxiety and depression, but what stood out to me was like the difficulty with some of her relationships. So kind of the relationship with her boss, and then the relationship she's in with her partner. So like those struggles with keeping that stable relationship were 2 things that I noticed.
There was some mention of alcoholism, her missing or being late to work meetings, and also personal events, planned events as well. Unpredictable mood swings and blackouts.
For me, so I agree with what everybody have said, and I also would like to add some dissociation symptoms, such as memory loss, having difficulty memorizing. She also have memory distortion and fabrication, which are possibly defense mechanism from her childhood, because the case mentioned that she remember her father abused her siblings, but not her, and she has this completely different memory of that. So that stands out and quite suspicious to me. Yeah.
I had a question. Is it common in these cases, like the part about her calling herself Miss, I think, or something like that? Is that not normal, but is that a common symptom where you kind of go back to these habits or things that you tie to that relationship that might have been like what you're disassociating from?
That's a good question. What do y'all think?
Can you repeat the question?
Like, I'm just curious about that specific part, about her calling herself something that might be what she's disassociating from, or like kind of going back to that point in her life, and it's something that actually relaxes her or makes her feel comfortable or confident, is calling herself Miss Chrissy, which is something she said that she was called in the earlier years.
Yeah, I suppose what I was confused about was, so was she abused or was her siblings just abused?
We don't
That was
know.
confusing as well, because it says she doesn't remember her father abusing her.
But I think that kind of plays in a little bit to what Victor was talking about with the levels of dissociation.
Yeah, because it's
Because
like, was she abused or wasn't she? And is she using the Miss Chrissy thing as a way to comfort herself and to cope with those negative repressed memories?
Yeah, I think you're onto something there, because at least from my interpretation of this, and I realize that, we don't know everything, which is also really normal when we have a client working with, we don't know everything.
Right.
But it sounds as though it says that she admits that she sometimes still calls herself this Miss Chrissy when she needs to feel special. So it sounds to me as though when she was a kid, that phrase made her feel special. Now, we don't know if that was in the context of trauma or in the context of family trauma, or if that was separate.
Yeah, he could have been using that to manipulate her into, making her feel special, and then, abusing her.
Yeah.
Oh man, that's
Yeah.
messed up.
It is.
It's terrible. Close relative abusing you.
Mhm.
But unfortunately, a lot of people experience this.
Yeah. Yeah. But I think that all 3 of you, kind of in talking about this memory piece and the Miss Chrissy piece, are really hitting on some like really important parts of the case study. because we don't know those things, and those are things that could be part of ongoing therapy, right? Is trying to figure out some of those components, and maybe we even came across a coping skill. I know, Victor, you named really wisely some like defense mechanisms, and it sounds like maybe we're also naming some coping skills that it sounds like despite all this family trauma, or whatever the details were, we know there's family trauma. It sounds like she's able to find things to still make herself feel good and like self-regulate.
Yeah.
Yeah.
I
And
think
you-
also, sorry.
Nope, you first.
I think also like there are some positive coping skills that she's using, but that substance abuse part is something that I would just kind of keep an eye on, just so that that doesn't become also the coping mechanism.
Yeah. What are other good coping mechanisms that y'all are noticing?
Thank you.
It's like she tries to. At first, she said she tried to not speak about her family. She used vague terms like a real horror show, but she wouldn't elaborate.
So some avoidance.
Yeah, avoidance. Then they said she leaves work early. I don't know. Maybe that's a coping mechanism. Maybe she gets too stressed and feels like she can't handle it, so she leaves.
I think also her being there is, I mean, a positive coping mechanism of her turning to the, like, at some point she said that her partner wanted her to be there or to speak out, but it is a positive thing that she is in the room, I guess.
It said she was trying to get him off her back.
Yeah.
No, that's a really good point that I sometimes when I have clients that I am frustrated by, I try to remember like, hey, they're showing up, right? They're trying to do something for themselves. And even if everything we're talking about feels like we're doing it wrong, they're showing up, right? And so there's always that positive thing. So good find, Khulud.
Yeah, we used to try to give them when I was working as a case manager, a housing case manager, because a lot of times the clients, they would not show up. And then so we started to give them little incentives when they would show up. Yeah, because it's hard to get some clients in.
Great point.
Also, using therapy is a way for her to maintain the relationship with her partner, because in the last part, she said that she doesn't want the partner to leave the relationship. And so going to therapy is actually a way for her to stay.
It also mentioned that she was thinking about leaving the relationship before he leave her.
Yeah.
But she didn't do it, so she's there trying to get help.
But that's a really good point, Victor, that it's again, we have to make some assumptions here. We can only have the information we have, but it sounds as though you're acknowledging that maybe there's multiple reasons she's there. It's not just because she wants to get better. There's also like a, oh, if I go to therapy, then, I'll stay in this relationship, which is valid. But I like that we can acknowledge both of those things, and that no matter what the reason is bringing her in the door, she's still showing up. And it sounds like she's doing the work, right? She's not showing up and talking about, I don't know, her cats for the whole hour. Nothing wrong with cats. Love cats. But therapy isn't about the cats, right?
Yeah.
So I love that even if she's sort of showing up and maybe coming in for some of the wrong reasons, that at least she's still showing up and doing the work. But that was a really good catch, Victor. Okay. Any other symptoms of complex trauma that we should name? I think you all hit a lot of really good ones.
I noticed when she when she reacts to what happened at work, she said, "This is what we get for playing by the rules," in "Stupid Girl." It's like she initiate these comments like she's talking to herself. Maybe those are reflection of like trauma response.
Yeah. Oh, do you mean like she's repeating things that she's heard in the past? Or do
Well, it
you,
doesn't say.
Yes,
okay,
the stupid girl one. This is just my hypothesis. Like just connecting the dots, but yeah, both
Okay.
of the statement. Yeah.
what were you thinking, Andrea?
No, I was saying because it really doesn't say why she's saying those things. She just blurts it out. It should, as if she is, she is talking to herself.
Yeah. So that's a great point. We don't know, but if we were working with her, we could try to explore that a little bit.
Mhm.
Yeah.
Yeah, because the context is right after she left work and then she come to the session and she said those statements.
Mm.
Yeah, and she left work feeling irritated. So it seems like something at work triggered her to say those things.
Mhm.
Mm.
Yeah.
And
Yeah.
I think we also had touched on like the gaps in memory. So I think like even when she wasn't drinking that much, or she said she had like a glass or something, I can't remember the exact, but it was like minimal consumption, she was still not remembering what was happening. So like that kind of memory gaps, I think, are important as well to know.
Mm-hmm. Great job ruling out substance use. At least drinking. We don't know about other substances, right? We
Yeah.
haven't asked about that.
Yeah. And well, she said she had one glass, but did she
True.
really have one glass?
Yeah.
Yeah, it does seem like from the beginning to the end, there's some changes as she kind of reveals more information.
Mhm.
You're right. And sometimes clients lie to us, right? Not even necessarily intentionally or maliciously. Sometimes that's a defense mechanism. So, yeah. Okay. Such good things. So I want to share a couple of slides related to complex trauma with some images. I love having pictures of things. That's how my brain works. So I try to share that with y'all as well. So let me share this with you. Here we are. Okay. Are you able to see that?
Yeah.
Awesome. So I wanted to give a little definition of complex trauma because I think it's important. I think you all named amazing examples of it, but sometimes, at least again, how my brain works, having really clear bullet points over kind of what's included and what's not can be helpful. So I wanted to start out here. So this is from the American Academy of Experts in Traumatic Stress, a good expert on this. So they said that 3 things are required. The first one being repetitive, prolonged, or cumulative trauma. So let's think about, in this case study, right, with Chris, tell me about, do we think that Chris meets that criteria?
I don't know if we have enough information to necessarily say specifically yes, but I think from her explanation of what her siblings or what, I can't remember, her family was saying that she could fall under that category.
Yeah. So I think it's important as we're thinking about this, and you're right, absolutely. There's some things we don't know, and that maybe we can be led to assume, but we don't know. But I think it's important to think about, even if she's witnessing some of these things happening to her siblings, we can still count that as traumatic, right? The definition of PTSD in the DSM allows for experiencing things not directly, but more indirectly through experiences of others witnessing traumatic events.
Mhm.
So we at least know that, and there might also be some own personal trauma that we don't know as much about.
Yeah.
The second requirement listed here, oh, I gotta move your faces for a second. Okay, is that it's usually interpersonal. So direct harm, exploitation, maltreatment from a caregiver, etc. So typically, and again, it says usually, it's not always, but it would not include things like natural disasters, more directly related to the interpersonal component. So how about that for Chris? Do we meet that criteria?
Yeah.
Well, they do mention abuse by her father, so that would
Yeah.
Yep.
would meet that one.
Definitely interpersonal. And then the third component, again, this is a usual, but that usually occurs at developmentally vulnerable times in the victim's life, such as early childhood or adolescence.
Yeah. She said that.
Mhm.
Yeah, absolutely. I want Oh, go ahead. Did I cut someone off?
No, I just said I agree.
Okay. Yeah. And I think it's important. There was a little asterisk on this one I wanted to share, that there are times also when complex trauma can occur later in life. Usually if it's associated with conditions of vulnerability or disability or disempowerment, right? So just thinking about this developmentally doesn't only have to mean age developmentally. It can also be, you know, if someone experiences a condition later on in life and there's some disability components to it, that there can be some complex trauma in those conditions as well. So, yeah. Good. Okay. So it sounds as though Chris might meet the definitions for complex trauma, which we're not surprised at because it's a case study about complex trauma. And I wanted to show this little diagram that I found that I liked because it talks about PTSD versus complex PTSD and some of the differences. So we can see the top half, right, is regular traditional PTSD. So I think these are things we've been talking about this whole class, right? So reliving experiences, avoiding experiences, emotional arousal, right? The hypervigilance, sense of threat, easily scared. All of those are things we've been talking about, and that can relate to single trauma events, right? And then the second half of the image talks about complex trauma. And so this is where we typically have repeated traumas, which you can see right below it. And so there's some of these other things that are added in that are more common with complex trauma than with traditional PTSD. That doesn't mean they can't come up around PTSD, but it means that they're more associated with the complex version of this. So that includes intimacy problems, feeling guilty, anger, feeling worthless, emotional regulation challenges, and relationship. And I was really good as we were talking earlier. I noticed you all naming some of these, right? You talked about mood swings. We talked about memory loss. We talked about relationship issues. We talked about using alcohol to maybe cope with some of these other feelings. So again, it's not black and white. I don't want us to feel as though we can't struggle with feeling worthless after a single trauma event. Like that's not true or fair. But I think we can notice that as we go kind of further down into this complex PTSD situation, some of these other things are a lot more likely to come up. I also wanted to just lastly, before we move on, talk about some differential diagnoses. So that means these are things that if we're thinking, oh, this could be complex PTSD or complex trauma, right? We recognize that sometimes there's other things that we should also be like, wait, what if it's this or what if it's that? Mm-hmm. This is exactly what Khalid, you did earlier, beautifully, when you talked about alcohol, right? You're like, oh, we know the memory loss isn't from alcohol because she says she's only drinking 1 glass a day, right? So you were saying, wait, there's memory loss. It could be from trauma, or it could be from alcohol, but wait, it can't be from alcohol. So we're like ruling it out, right?
But sorry, just to cut you off in one,
please.
You can have more than, like, she could technically have both the substance like abuse and have complex PTSD as well, right?
Yes, absolutely. You read my mind. That's the next thing. Beautifully done. So yes, you can absolutely have more than one of these. And in fact, oftentimes with trauma, there are comorbid diagnoses when we have more than one. So that is really normal. What we don't want to do is give a diagnosis, oh, this is complex trauma, and then find out it's really just substance-induced stuff, right?
Yeah. Yeah.
So if we're going to diagnose both, they both have to be accurate and true. Yeah. So these are some things that are oftentimes could be differential diagnoses for complex trauma, right? So one of them is regular PTSD that we talked about a minute ago, like a single trauma event. We have some dissociative disorders, which we're going to talk about more in detail later. But the current DSM for diagnoses has these 4 different dissociative disorders that are components that, if all of this stuff is dissociation based, could be that. Borderline personality disorder, I know it's a personality disorder, but has been found to be very frequently trauma based or trauma related. And so a lot of the interpersonal challenges, right, with relationships, mood swings, that very much aligns with a lot of the borderline personality disorder traits. Substance use disorder, which we talked about earlier. Acute stress disorder, which it can only be diagnosed right after a traumatic event. So in the first 30 days. So that, some of these, the symptoms are what differentiates the diagnosis, and some of these, it's more based on time frame. And then we have depression and anxiety, which we know can be components of trauma, right? You mentioned that earlier. I think it was Andrea, you mentioned the depression component. So absolutely, those are things that could be part of a complex trauma diagnosis, also can be standalone. So if all of the things we noticed were related to depression, or all the things we noticed were related to anxiety, then we want to give those diagnoses instead of recognizing a complex trauma. Does that make sense?
Yeah.
Okay. So let's go back to Chris and our case study. What do you all think? Are any of these things that we think might better define what's happening for Chris, or do we think that there is some complex trauma stuff going on?
I'd have to pop open the DSM.
That's valid. Yeah. Have you all had that class?
Yes, that was fun. We had live discussion where we had to rule out all of the what is it called again? The different diagnosis, differential diagnosis. Yeah,
Okay. Okay. So you've
that
done
was
this
fun.
before.
But
You know how
we
it
did have the DSM-5 open, and we were like, "Oh,
yeah. Good. Yeah. So
but yeah, a lot of these are close. Yeah. So yeah, we'd have to look at the criteria, pick through it.
Yeah, I think there's
So-
definitely some that might overlap, but I do think it's more of a complex.
Yeah, I think it's easier to just say complex.
Yeah, I think it's a complex trauma because from the information that we gathered, it is likely that she experienced some trauma since childhood, and it has been unresolved. And so as she grow up, things just get like more suppressed and accumulated. And so the symptoms of depression and anxiety and mood swings are just like on the surface. Of course, they integrate together as like a whole sponge or whatever. But the main theme is complex trauma.
Yeah, I think I agree with you, Victor. And there might be some of these other ones that are also true. And so if we had to, give a formal diagnosis, we could look at, maybe a couple of them are at play. But for our purposes for today and for more of our case conceptualization, I think you're right that we can stick to there's complex trauma going. Yeah. Awesome. Good work, all. Let's go back to our discussion and look at the next question. Which is, oh, my numbering's off, number 2. Some common signs of dissociation. So I know Victor did a great job hitting on some of these earlier, but let's go into a little bit more detail. What do we see as the signs of dissociation?
I think one of the ones.
mentioned all of them. I'm sorry, go ahead, Cool.
I think one of the ones is that she calls herself Miss Chrissy, and that's like could be another identity of, I mean, that's again assuming, but it could like potentially be a way that she disassociates herself from who she is, and that's kind of another like a way to disconnect from herself.
Yeah, I mean, yeah, I guess the Miss Chrissy, along with the fact that she completely like doesn't, remember being abused at all. Let me see, the blackouts, maybe. They didn't go into detail about the blackouts, but definitely that and loss of memory.
Yeah, and the memory thing also, like when she's asked a question and then she kind of doesn't answer for a few minutes, it says.
Yeah,
and then
so she
when
stares
she's
off
asked
into
about her
space.
history, it's kind of confusing. So she's kind of, yeah, like she's kind of in and out of being present in the conversation.
Avoiding eye contact, I
Yeah.
mentioned. And staring off into space.
I think that eye contact one is interesting because it absolutely could be a form of dissociation, right? Of like not being able to be focused and present. It also could be social anxiety and talking to a clinician about hard stuff. And so that's one of those that, you know, I'm not disagreeing with you. I think it absolutely deserves to be on the list, and I wrote it down. But also we have to make sure that we're being mindful of, okay, is this really dissociation, or is this anxiety, or is this, you know, it also could be a sign of, like, you know, autism. There's a lot of other components of that go into these. And so as we're working through this case, being just mindful of those things is important. Anything else that are signs of dissociation we see in Chris?
I feel like we hit all of them. Mm,
I think also it says in the paragraph about the work, and then it says in the session the counselor offered supportive, encouraging statements, and then she kind of glares at her, and then she starts crying. So it's like kind of, yeah, I would put that just under something to note, I would say.
Yeah. What do you think that was about?
I don't know. I
seemed
think
like she
maybe,
got overwhelmed.
yeah, and it was during a period where she was kind of having a lot of negative self-talk. So maybe hearing a positive reinforcement isn't necessarily, maybe it like triggers her in something. I'm not sure.
I'm saying maybe she needed to hear that, you know, and not necessarily her crying, you know, because she's upset with the counselor.
Yeah, true.
So you're saying that if I'm understanding you right, Andrea, that the crying is like a almost like a relief of, like, wow, someone's being nice to me. Like that approach? Is that right?
Yeah, like a release almost. 'Cause it
Mhm.
seems like she's been doing everything to avoid negative feelings, but it's also making things worse. Her trying to avoid everything. And but she's not hearing anything good from her boss. Her boss is getting on her, and her spouse is getting on her. And so all of that, she's dealing with her symptoms as well. And then just hearing something encouraging is kind of like, wow, I needed to hear that.
No, I think that makes a lot of sense, that especially if there's, as we now know, I know at the time, right, we didn't have all the information at that time, but later on, we now understand that there was a lot of trauma and a lot of, sounds like, negativity. And so in a world that has maybe always felt negative, to hear someone being kind, being open, asking, you know, curious questions, definitely could have been like a release. Yeah, and I think if I'm remembering correctly, that's around the time when kind of she then starts opening up more, the therapist. So maybe like a really big turning point of, like, wow, this person sees me as a person and not just as, you know, all these challenges or failures.
And interestingly, she begins to talk about her father right after that too, saying that he was a loving father.
Yeah.
Wow.
Yeah, so that part makes me think of that we should be careful when we distinguish between personality disorder and trauma with dissociation, because with dissociative amnesia or with multiple identity disorder, when another personality talks, that personality may alter the fact of the event, or you know, just make up of a whole different memory set. And so that would be hard for the counselor to navigate which direction to lead in, or how to understand the client.
Mm-hmm. Yeah, great point. And I think we mentioned that earlier with the Miss Chrissy too, right? Of wondering, is that kind of like a multiple personalities component, or is that more, like we talked about earlier, more her identifying, like this was a phrase that felt really positive as a kid, and so when I'm feeling down, I want to bring this back up. Yeah.
I like this thing I found in the book. It says working with clients entails understanding their character, because any retelling of past or present experiences takes place through the interpretive lens of character.
Yeah. That's a great quote. Tell me how you're applying that to Chris. I think you're right on the money.
Because like you said, or like you guys mentioned, the personality could, the possibility of personality disorder. But to me, it still go right back to dissociation, because she's telling it through this character, or she has this character created by her father, actually, and also her abuser, which is interesting. But as she retell the story, she's telling it from the Miss Chrissy character, saying that her father was loving and he didn't abuse her.
Yeah. So it sounds like that very much backs up what Victor was saying, that we have to be aware of, if someone does actually have these distinct personalities, right? Being aware of kind of which one is sharing the information, and that might be different from perspective.
Yeah.
Yeah. Just like after today, we're all five going to have different, we were all here together. We're all five going to have different, ideas or takeaways from the class, right? So in a very similar way, one person with multiple personalities, also each one has their own perspectives. Yeah. Let me share with you more pictures. Again, I love pictures. I warned you about this. A few pictures about dissociation, since you all found them well. So we're going to start with definitions. I also love definitions. Because if we're talking about dissociation, I want to make sure we acknowledge all the different pieces that kind of can be a part of dissociation, right? So we have disruption, interruption, discontinuity of normal, subjective integration of behavior, memory, identity, consciousness, emotion, perception, body representation, and motor control. This is a very long definition, but we can notice, right, there's two parts. There's the disruption piece, and then there's what it's disrupting. And so we have memory as a piece of that, but also behavior can be different. Identity can be different. The way that the body is can be different, right? Views of body or the way the body is carried is different. So all these different components can kind of be affected by the dissociation. And then in terms of what it looks like, I think you all named some great examples of this. So staring into space, you talked about loss of time, you talked about also losing train of thought and just general confusion. And I think Chris has some general confusion, right? In terms of even the way it's presented, it feels like a lot of really confusing information we're given. We don't know a whole lot. And that might be because she also doesn't always know a whole lot about her own life. And now my picture that I love is the spectrum of dissociation. So back when I was in graduate school many years ago, we talked about how dissociation, right, sometimes has this negative connotation, right? There's a whole section in the DSM about dissociation disorders. And sometimes there is this idea that dissociation is bad. And dissociation can be problematic, can be hard, but there's also, it's a spectrum. And so there's components of it that are normal. So one of my professors had told me once that this example, right, that we all dissociate every day. So if you're ever driving home, you get home and you're not really sure how you're there, but you're home and you're safe and you know that your body just knew how to get there, right?
Airplane mode, yes.
Yes, airplane mode, exactly. That's dissociation, where your brain didn't have to be 100% focused on the road because you drive home from work the same route every day or whatever. So you got home and your brain was doing other more important tasks. So you were dissociating from the road, but that's not a bad thing. You are still being safe, right? And if there was an ambulance that went by, you would have refocused on the road. So that is our everyday, normal, healthy dissociation. Like dissociation has healthy components. It only becomes problematic, right, if it goes too far. So after the everyday dissociation, we have checking out, zoning out. So maybe if you're in a really boring class, but never with Dr. McCormick and I, you might zone out sometime, right? And that's like a normal thing that sometimes we do. I know for me, I'm an introvert. So sometimes if I'm overpeopled, I zone out for a minute to kind of get myself and my energy back, and then I re-engage with people, right? That's not an unhealthy thing that I'm doing. That's part of my personality. And so I'm taking care of myself by giving myself a little people break while still being physically present, right? There's ways in which that's not unhealthy. In certain settings, it might not be great, but certain settings, it's fine. Then we start kind of getting into more of the trauma-based ones. So we have the PTSD, the trauma, the dissociative amnesia. So those pieces where we're beginning to see this is more problematic, but not to the extent maybe, of course, of like having different personalities, right? So this is more normal. So let's see here. Sometimes my former job, I used to work primarily with survivors of trauma. And sometimes I'd have clients that would be talking and then suddenly they would kind of stop talking, stare at the wall, right? So I knew that they were dissociating. They were still themselves. They were still in their person, but their brain was kind of elsewhere for a minute. And so then I'd know that and I'd, track that. And I'd be like, okay, sounds like we need a little break. Let's do some stretching, right? And we'd do some stretching together, bring them back to their bodies. We could keep going with the session. So that's dissociation. That's trauma-based dissociation, but they're still their same selves, right? But then when it gets more to the pink area is where it becomes some of these disorders, right? So depersonalization, derealization, so like, separation from self, from body. And then all the way at the end, as Victor was noting before, is dissociative identity disorder. And that's the point where we kind of have these distinct personalities. But that is one of the far ends of dissociation. So I don't want us to always go there when we think about dissociation, because that's the most abnormal form of dissociation. I think in my career, I've only had 1 or 2 clients that actually qualified for that diagnosis, right? But having some sort of trauma dissociation, that's a really normal thing in clients that we work with. So there's my picture for you for the day. And then I did just want to briefly, as I promised it earlier, just name, right? These are the 5 different dissociation diagnoses in the DSM. It sounds like you've all had this class, and so all kind of know about these. So I'm not going to go through them in detail, but obviously we talked about DID, right? Distinct personalities. Dissociative amnesia has to do with memory, so not remembering information that's important about the self. Then we have the depersonalization, derealization, right? Feeling like we're seeing ourselves from outside our body or sensing things that aren't real in our bodies. And then we have our other specified and unspecified, are kind of the catch-all for things that are clearly dissociation diagnoses, but don't fit beautifully into any of these other sections. Any questions about any of this dissociation stuff?
The depersonalization one. Mm-hmm. You said feeling things that aren't real in our bodies. Can you explain that?
Yeah. So the depersonalization component, and if we want to get the DSM, we can do that and go through it together. But briefly, the depersonalization, right, is feeling like we're seeing ourselves from outside our bodies. So like depersonalized, so out of the person. So that's if you've ever had clients that talk about seeing like themselves move around their life, but not feeling in their bodies. Right. So like, oh, I saw myself walking over to the fridge and getting a glass of water, but I didn't feel that. That's the depersonalization. The derealization is feeling as though things around you aren't real, right? Like I'm not in my reality. So that would be like, I know I'm doing these things, but like this glass of water isn't real. It's just in my mind. That's it. Dr. McCormick, did you have a thought on this? I saw you unmute.
The only, not necessarily on a depersonalization or derealization, but just as one of the things that I use pretty frequently in my practice, and especially when I have new folks who come to see me for EMDR therapy specifically, is screening for disassociation. And the one of the most common screeners that we use to measure how much someone's disassociating is the dissociative experiences scale. We're in the second, it's the DES2. So we're in the second version of that. There's an adolescent version as well. But it's a really sort of like a good way to kind of get a snapshot for, okay, how much is this individual, like going back to that previous slide that Kelsey had, how much is that this individual like in the pink, and how much is that this individual kind of like moving towards some of that more dissociative type, more, let's say, problematic or a little bit more outside of their body than we are typically used to in our everyday, day-to-day.
Yeah, I'll show that scale real quick because I also have used it in my work. So this is the scale. I don't know if this is the exact one that you used, Dr. McCormick. I've found a couple different versions that some are easier and harder for clients, it seems.
Yes.
Yeah, but I know this is very small writing, but this talks about things that could make someone feel, could be indicators of dissociation. So one is the one I already gave, right? You're driving a car, you don't really remember how you got home, etc. And there's a whole bunch of different examples here. So finding themselves dressed, don't remember putting on clothes, or they got to some place, they don't know how they got there. They're approached by someone they don't know and they call them by another name or insist they know them, right? So all different levels and versions of dissociation. And then the way that folks fill it out is you mark down in its percentages about the degree to which it applies to you. So 100% is like, this is always me. 0% has never happened to me. And so you're kind of able to kind of figure out how frequently things happen, and there's a way to score it at the end.
Mm-hmm.
So just a little more.
Yeah,
information about that.
that's what I wanted to mention. So
No, that's great. Yeah. Other thoughts on dissociation before we move on? Going once, going twice. Okay. So I think next we're going to start thinking more about what we do with this knowledge. So the next question, there are several do's and don'ts when working with complex trauma and dissociation. So we're going to imagine that we are the role of the counselor of Chris. Chris is our client. So what are some things that we should do or some things that we should definitely not do?
So I think of the things that we definitely should do is to embrace the humanistic approach, which is, unconditional regard, empathy, and genuineness. Because as we read in a case, because the counselor provide unconditional regard and support, Chris was able to be more open up on her issue. And so with cases about trauma, we need a lot of patience. So that's another factor that we need to do, is to be patient with the clients, because it's not easy for them to talk about trauma, and even more uneasy for people with dissociation to recall trauma. Yeah, and so another one would be do not and to follow up with the client's emotional status when we guide client through our intervention. There might be times when client feel overwhelmed, and we should always be mindful of that and check on their emotion status.
Yeah, that's a good, Victor.
Thanks.
Yeah, I definitely agree with the be patient thing. That was one of the things I had listed. and the positive emotional regard. But also, let me see what else I had. Oh, help them recover repressed material. Both like what happened and the effects of what happened.
Mm.
And then kind of explain like the etiology of the problem, or explain, psychoeducate them about dissociation. That's all I have.
Yeah. Can I go back to one thing that you mentioned that I want to discuss briefly, and then I know, Khalid, I don't want to leave you out either, but you talked about recovering repressed memories or material, I think was your language. And I'd love to hear from you all. Do we think that, or what needs to happen before we can do that?
Yeah, I was gonna say one of my don'ts actually was not to like put too much pressure on uncovering what the traumatic memory is necessarily. Just because like the like we said, the disassociation might be a version of like a coping mechanism or whatever. So I think trying to pressure that, and not that you were saying that, but just that kind of concept of trying to uncover it might be like we have to make sure it's not premature, or like that it doesn't trigger so that more symptoms come up, or that
Right. That's why I also have the be patient thing as well. I said that.
Yeah, exactly.
Yeah, that's a really, really good take. And I love that you two kind of both had pieces of that are both good when integrated together, right? That there are ways in which understanding repressed memories can be useful, but also we have to be really mindful of when we're doing that. The code of ethics, right, says do no harm, and uncovering and doing trauma work is one of the areas in which harm can easily be done clinically.
Yes.
Right. And so making sure that we're being really mindful around that. I'm not certified in EMDR, which it sounds as though Dr. McCormick is, but I do know that one of the kind of earlier stages of EMDR is basically, and there's a name for the stage that I have forgotten, but basically like making sure that the client is ready to do the work. And resourcing.
Yep, resourcing.
And making sure that the client has all the abilities to be able to handle the information. So, right. So having coping skills, having support systems, knowing how to handle the mood swings and the big feelings, right? And only when a client has all of that stuff ready and they're able to manage and cope, then should we start trying to do any sort of memory unpacking? It also doesn't have to happen, right? So maybe the brain has repressed it for a reason. Maybe we need to respect that and kind of believe that anything that we need to know will be uncovered if and when the client is ready and useful. So a lot of trusting our brains. They're wild. Brains are wild. And they do crazy things. And they're trying to keep us safe. And so sometimes we should let them do their job well. Yeah. So I'm not saying that you were wrong, Andrea. I think you have a good point. I just wanted to add a little caveat that we have to be really careful with that one. Yeah. Okay. Totally. Did you want to share more from your list? Didn't mean to interrupt.
Yeah, my other I had said that create kind of a predictable and consistent schedule and structure to sessions, I think is important. Like she had mentioned that like anything that went outside of like specific structures, sometimes like with individuals with complex trauma can become chaotic and unpredictable. So it's kind of important to have that predictability within the sessions. So it's more of an overarching I would say.
Yeah. Yes. Y'all named so many good ones. I can show you my list in a second, but were there any don'ts that we wanted to name as well?
Yeah,
We kinda
definitely
hit-
don't push the, oh, sorry.
Go ahead, Victor.
Okay. So I wrote down, don't rush into trauma exposure or rush to push clients to meet our goal. So either rush to kind of rush to exposure or rush to the goal that we set for clients are the things that we shouldn't do. Also, we shouldn't underestimate clients' traumatic experience. So it can be easy that we have bias towards some specific traumatic experiences and underestimate some others, and so that can be dangerous for us to like in the work of counseling.
Yeah. Yeah, what a good point. A little caveat, I was reading an article last night for I'm in the doctoral level of the trauma class. So I was reading an article, but talking about how for interpersonal violence or how it's easy that based on the gender of the perpetrator, sometimes clinicians will underestimate the severity of the situation, right? Where if it's a man, right, then we are, oh, this is terrible, you have to get out. If it's a woman, then it's like, oh, you should be able to talk it out, right? And so I think that's exactly what you were pointing out, Victor. I realize a different situation than this case study, but exactly what you're pointing out, that we shouldn't assume that because of certain demographics or certain factors of the trauma about how bad it is or not. We have to believe our client when what they're telling us and their experience.
And I think going off of also what Victor's saying, and like while I was reading it, I subconsciously immediately thought, okay, she was also abused, let's say, or she also experienced it, and she's disassociating from those experiences. So trying not to jump to conclusions of what those repressed memories are and kind of meeting the client where she's at rather than trying to piece the story for myself, even as her therapist.
Yeah. Oh, great self-awareness.
I've seen another one that talked about how we shouldn't, basically the same thing she was saying, try not to put false memories in their head, allow them to, tell us what happened, and also I had validate feelings.
Yep. Good things. Are there more on the don't list that y'all wanted to share?
That's pretty much what I had. You already said the try not to further harm the client. I had that listed. Yeah, that's it.
Yeah.
Any for you, Khulud?
I think those are all of them. I had put the like not pressuring her to disclose.
Oh, right. Yeah. Okay, let me share with you mine. We'll compare. Although honestly, I liked a lot of what y'all shared. I want to add it to my list now. Where were we? Here we are. Okay. Oops, not there. We already did this. Okay, here we are. So things we should do. Offer choice, right? So this is only, even in the small things, we should make sure we're always offering choice. This is part of some of the things that you all mentioned, right? In terms of empathy and unconditional positive regard, but also people who experience trauma didn't have a choice in their trauma. And so they should be able to have a choice in their healing. So I do this really intentionally with all of my clients, even small things. Like when they come into my office, I don't have assigned seating. I say, sit wherever you'd like, right? Some people like to sit next to the door because it feels safer. Some people sit next to the window because it feels safer. Some people sit far away from me as possible. Some people sit close to me as possible, right? Like every client has their own place and their own factors that help them determine where they sit. And that's a small thing that I can do from the very beginning, before I even had any conversations with them, before I even know if they have a trauma history or not. A small thing that I can do to help them feel safe and validated and like they have some choice in their healing experience. Empowerment, you all mentioned that, empowering client voice. Boundaries, you guys mentioned. That's a really important piece for me as a clinician. Respecting names and pronouns, right? Which this trauma may or may not be related to those things. Where I work now, my population is probably 80% LGBTQ. And so those are things that are especially important, where if someone's talking about trauma from their gender identity or sexual orientation, I have to make sure that I'm being really careful not to re-traumatize that. Avoiding judgment. I think you all know, listen to that one too. About emotional validation. Yes. So very much in line with what you all said. Things not to do. Label their experience. I think it's especially important. I used to work with a lot of survivors of sexual violence, and I had to be really careful not to label them, right? The organization I worked for did have to use certain labels because of like grant funding. And so there would be labels we would use in-house, right, of survivors, et cetera. But working with folks, sometimes folks don't like certain labels, right? Some people would say, I'm not a survivor, or I'm not a victim, or I am a survivor, or I am a victim, like, or neither of the above. And so making sure that we're not labeling that. So in this situation with Chris, right, we don't want to label, oh, like you grew up in an abusive home, right? Like we don't want to use those labels if that's not the label that she's using for her experience.
Right.
Being mindful that whatever language the client uses, we utilize that same language. Don't require a healing time frame. I think Victor mentioned something about that, right? Of like going at their pace. Not questioning specifics or specific responses. Doesn't mean we can't be curious clinically, right? We can ask the curious questions like, oh, help me understand this. Tell me more about this. What was it like as a kid? Those things are fine. But asking like exactly at what age was your sister first abused, et cetera. Like those things are not things that matter clinically and that are not helpful for us to ask. And then not asking why they didn't react a certain way. So I know that's something where sometimes non-clinicians will get into like, oh, why didn't you leave your family sooner? Why didn't you leave the situation? Why didn't you tell someone at school what was happening? And those are things that are re-traumatizing and traumatic for the client. So we have to make sure that we're using the unconditional positive regard, that we're being patient, that we are being understanding, all of those pieces of meeting the client where they're at. Yeah. So that's my list, but I think you all hit a lot of these and had some other good stuff too that wasn't on here. So good job. The next piece that I wanted to share with you is this beautiful picture, because I love pictures, as you now know, about the window of tolerance. So when we're thinking about strategies for working with survivors of trauma, it's important that we're aware of where the client is and their emotional regulation so that we are able to work with them successfully. So have you all heard of the window of tolerance before?
No.
I feel like I have.
Okay, so I'll share a little bit about it without being repetitive for those of you who've heard. So this green area is the ideal place for learning and for growth. And this idea can be used outside of counseling sessions, but I'm going to apply it to this case, right? Where for Chris to be able to grow as a person and work through what's happening for her, she has to exist in this window of tolerance. And it's really easy for people with complex trauma to cause a client to leave the green zone and either enter the red zone or the blue zone. The red zone is the hyperarousal zone. So that's when we're being overreactive, emotionally distressed, unclear thoughts. This could be anxiety symptoms. This could be panic symptoms. But a client who is not able to calm down and enters hyperarousal. And once they're in that space, we can't do any productive work in terms of processing trauma, understanding symptomology, learning coping skills, right? A client isn't going to be able to do anything in that state. So when we're in the hyperarousal state, we have to use mindfulness, grounding, and breath work to be able to go back to the window of tolerance. Once we're back in that green window, we can then resume the work that we were doing, right? Another way that someone can leave the green zone is through shutting down, going into that hypoarousal, right? So this very much can mimic the idea like fight or flight is the red zone, freeze is the blue zone. So if a client is shutting down, they are depressed, lethargic, numb, unmotivated, maybe dissociated, even can kind of go into this category a bit, where they're not able to be present, they're not able to function, learn, grow, process, whatever. And so once again, we can use mindfulness, breath work, and physical activity to help them get back into the window of tolerance. So whenever we have a client in session and they leave that window, then we have to switch tactics, switch gears to be able to kind of help get them back. Yeah, I think that's kind of the basics of it. Are there any questions about that for those of you who this is new?
In your experience, if a client goes into one of these things, is it hard to get them back into the window of tolerance within the session, like within one session, or is it?
That's a great question. It depends on the client.
Okay.
So, let me think here. I had a client, one of my favorite clients at my old job. Worked with her for, I don't know, 4 years, I think. And she would frequently go into the hypoarousal where she would shut down.
Yeah.
That's because her body kind of freeze was her common trauma response. And so in session, if she was triggered, she would freeze. So her body would go numb, would go stiff. She'd kind of do some staring, and I could tell that she was like no longer present. And when I noticed that, I would be like, okay, like, come on, Kim, let's stop for a second. Not real name, obviously, not breaking confidentiality here. But we'd talk about, okay, like, let's sit up straight, let's stretch, right? And so we'd always do lots of stretching. We'd stretch, we'd massage our muscles together, move around. I'd always tell her, have a drink of water. She always brought a water bottle with her. But she was really good about quickly getting out of that hypoarousal and getting back into her body and then continuing the work. Other clients, it's not so easy. I had a client a couple weeks ago who came in, very much was like in this hypoarousal depressed state. Wasn't really interested in getting out of it, didn't really want to get out of it. He just seemed like that's just where he was.
Yeah.
And so we talked a little bit, talked about some coping skills, but we weren't going to be doing any processing work during that session. It was just about, okay, I want to give you the skills to try to get out of this place that you're in.
Yeah.
So it's a great question. It kind of depends on the person in the session. Yeah.
It was a great question.
Other questions on the window of tolerance?
No, you just wrapped it all up.
Yes, good. Okay, then the last picture I want to show you, at least for this section, is some grounding techniques. So these are 5 of my favorite grounding techniques. And we're not going to go through them all. I think some of them are pretty self-explanatory. So water is like, drink some water, put it in your face, right? Breathing deeply is breathing deeply. And I do appreciate the idea of like, breathe in slowly, hold it in your lungs for 5 seconds, release for 5 seconds, right? Like that counting piece can be really helpful to help actually breathe deeply. Sometimes clients are like, think they're breathing deeply, but they're kind of just hyperventilating. So the counting piece can be helpful. Stretch and move is pretty obvious. I like the body scan. Sometimes I add in some like prolonged like muscle tightening and releasing, right, into there as well. But my favorite is probably the 5, 4, 3, 2, 1, the first one. Have you all heard that one before?
Yeah.
Okay, so
Yeah.
it's using our senses. So 5 things you see, 4 things you feel, 3 things you hear, etc. That can be really helpful. And I like that it's good that you can even do it virtually, right? So I can be like, oh, Victor, tell me something you see around you. Maybe you'll tell me about the curtains behind your head, right? Like you can do it even in different spaces, which is nice as we've kind of moved more into virtual therapy. So yeah, can you pick one of these to do right now real quick, just as a little way to break it up? Okay, I'm gonna pick one. I'm going to pick the stretch one because I love that. So can we all just stretch our bodies in whatever way you want to? Oh, yeah. Stretch. Good. Good, good, good. Okay. Thank you. I love the little break. Okay, so little techniques for you to be able to keep in mind.
What was the body scan one?
The body scan is, I can share it again so you can read it, but basically it's being aware of your body. So starting with your feet on the ground and just paying attention to what it feels like, right? So what does your body feel like? What does your toes feel like inside your shoes? How do your ankles feel? Mine are cold. Paying attention to what it feels like and going up your body. Sometimes you can add in some like muscle, like a muscle contraction and relaxation into that as well if you want to, right?
Okay.
Yeah. Okay, but I want to be mindful of time. I know we have 15 minutes left and we have 2 questions remaining.
Do we?
I think.
Yeah.
Okay, I thought so. So let's move on to the next one. And of course, if we have questions along the way, please feel free to ask them. I'm not trying to keep you from asking your questions. So, fourth one, ethical or legal concerns that might arise in working with this client.
The only one I had listed was the protect client and the try not to re-traumatize them.
Mm-hmm.
That's pretty much all I had for that.
Yeah, I had put the same, the traumatization. And then I also put like making sure you're handling counter transference. So that's something important. And then cultural competence as well. So
Mhm.
like making sure we're aware of Chris's cultural background and that we're being respectful of that. And then the last thing that I said was making sure to have accurate documentation of the sessions. So like record keeping and yeah, just so that we're like legally.
Mm-hmm. Yeah. Why do you think that one could be more important in this case? Because I agree with you. It's important.
Yeah, I think just having like records that are, especially with trauma cases, and just in case there is anything that's like goes into the legal system, or if she is a harm to herself or anyone around her. So we have those records, I would say.
Mm-hmm. Yeah, absolutely. I think you're right about a lot of that. We know that there are some mood swings, and so we want to make sure that we're assessing for like suicidality, homicidality. We have to document that because if, God forbid, knock on wood, right, Chris were to commit suicide, we don't want to have that be undocumented, that we were assessing and doing our best effort to keep her safe.
Yeah.
Yeah. And especially if there was some dissociation that got to the point of like different personalities, right? Like a DID piece. One personality might not know what's happening in the sessions with the other personality, and there could be some challenges for the client internally that even could potentially be part of a legal battle in the future. So we want to make sure that we're documenting appropriately. Yeah. Victor, do you have anything else from what was already shared?
Yeah, so for the ethical one, I would say confidentiality. So protect that. Respect client's autonomy. Do no harm. For the legal one, mine is kind of similar to what you all have said, and that's because of the dissociation symptoms. Just to be, just in case if the dissociation evolves into something more complex, and we have some document to rely on.
Mm-hmm. Yes. Oh, good points. Good points. Let me show you the ones that I had written down. Where are we next? There we are. So I took all mine from the ACA Code of Ethics, which hopefully you've all had a class on ethics, or at least regarding ethics.
Mm-hmm.
Good. That's very important. So mine very much mirrored yours. So avoid harm. I think you all said that, right? We don't want to re-traumatize. Also don't want to minimize or invalidate. Informed consent, I think, is really important. It's also really interesting that we have to be mindful of informed consent if someone has various personalities, right? Which in this case, it sounds like we didn't know that when we started working with her. But if we are aware of that working with clients, we need to make sure that all the different personalities or parts are aware of the informed consent and are in agreement with treatment. So that's kind of a really interesting case for really extreme forms of dissociation. So that includes both the informed consent and the release of information, where if we're going to be talking about the client with someone else, we have to make sure that all parts are on board with that. And it also supports empowerment, which we know is so important in working with trauma, that the client feels empowered, right? So I know for all of my clients, I always make sure I don't just have them read my informed consent form. So I wrote one. I'm the head of the Department of Counseling here. I don't just have them read the release of information form or the informed consent. I physically go through it with them because I don't want there to be any doubts in their mind of what's happening. And at any point, if someone wants to change something, wants to revoke informed consent, whatever, I always 100% support them in those decisions because I want them to feel empowered in their journey towards healing. Again, because they didn't have a choice in their trauma, but they have a choice in their healing. So that's really important for me. Also maintaining boundaries, which I think was named earlier, that encourages a feeling of safety, especially again, if trauma is oftentimes a violation of boundaries. And so making sure we're maintaining that in the counseling space. And then it also helps to prevent re-traumatization, where I never, I have very, very strong boundaries working with clients who have trauma, because I never want there to be any concern about, you manipulating or engaging in certain ways that could be potentially triggering for them. And then lastly, also important is ensuring professional competence. And I know that was mentioned in terms of cultural competence, but I want to expand that also to modalities. So there are different forms of modalities that we can use to work with folks who have trauma, which I think we're going to talk about next. And we have to make sure ethically that we're not using a modality we're not trained in. So I said earlier that I'm not certified in EMDR. There's a very long and expensive training that I would love to do someday to be able to be certified in that, but I'm not right now. So I will never use EMDR with a client because it's not within my competence until I'm trained, and then I would love to be able to use it.
How long is that training?
Oh, that's a great question. The one that I looked at previously, and that was when I was living in Pennsylvania. So it might be different in Ohio, and Dr. McCormick can maybe help us out with that. But the one I was looking at was a couple different weekend immersions, and then you have to be have some supervision along the way for someone who's certified to demonstrate that you're doing it appropriately.
Right.
Yeah, it's a
I think that was
40-hour.
so interesting.
The basic training is a 40-hour training, and then there's 10 hours of consultation that goes along with that 40 hours.
Oh,
So it's
okay.
50 total hours, complete basic training.
And you said it's expensive, Kelsey?
It was when I was looking at doing it in Pennsylvania. I don't know what it's like
It
in Ohio,
can.
but when I was looking at it was a couple $1,000s.
Yeah.
Oh, okay. I'm in Maryland. I
Okay.
gotta look into that.
Yeah, I would recommend it. I think it's a great opportunity, and I love the different components. So like the resourcing piece, right? I'll kind of take that piece out because you don't have to be certified to do that piece. So I love the skills, but I would never do it with a client until I was certified as part of following the ethics.
Thank you, guys.
Okay. Mhm. Oh, go ahead.
I was just saying thank you.
Oh, yeah, of course. To our last question, which is a fun one because it's more personal for y'all. Let me pull it up here. It can be challenging for a counselor. So if we can think about what would be challenging for you and how you would address this challenge.
I had countertransference. Because I might be triggered by the mention of, the childhood abuse. And to deal with it, I will just, monitor myself and just try to stay self-aware. And if I had, and if it really triggered me, I would just go to supervision and maybe try to get someone else to cover that client.
I think working with clients with trauma, and this is significantly based on some of my personal experience working with a client with trauma, and the most difficult thing is to see the light and guide them with that light. So there are times when the trauma is too dark, and it can even suffocate us to see the story in the client's lens. And so it may be very overwhelming for us to come up with a solution or come up with a treatment plan or a guidance for a client to go. And so that would be a difficult part to some of the complex cases. But once, like personally for me, once I break that part, the next step would be more, less difficult.
I like that.
Yeah, I also said, I think kind of dealing with the ups and downs and the breakthrough sessions, and then sessions where you feel like you're like 10 steps back. So kind of having that that feeling of ups and downs of sessions and the frustration that might come with that would be difficult. And then for me as well, what I put is a bit cultural. Like a lot of what I'm learning is obviously in English. So just having that like language to use when I'm working with clients that might be speaking in Arabic only, or like, so that could be a challenge. Or in Egypt, there's not really there's not really a DSM, like there's not those things that are available, or like legal considerations aren't necessarily like that clear, or documentation. So all of these things are kind of would be difficult in that sense. So kind of seeking supervision and making sure that there's somebody here like a more like a supervisor that's been doing it for longer, I would say.
Yes. Oh, I love those points. And I'm so glad that you brought up the language piece. I think that's
Yeah.
important as part of the cultural considerations. And one thing that I think is important around that is I've had consultation with some of my supervisors in my life around language regarding trauma, right? Where it can be hard for a client who is processing trauma and with you in session in a language different than the language that the trauma happened in, right?
Yeah.
So for instance, I have a client now who experienced sexual abuse as a kid, and they are Hispanic, and so their family of origin speaks Spanish. And so then they were telling me about it in our counseling session in English, because I speak English primarily. And so, you know, I had to be really mindful and really aware of, you know, is this being culturally competent? Should they be referred to a Spanish-speaking therapist, right? How important is it for them to be able to speak in Spanish to process the trauma that happened in a Spanish-speaking household?
Wow.
Right. And so I ended up offering them the option if they wanted that, but that wasn't the primary focus of our work together. So I didn't feel the need to refer them out, but making sure that I'm being mindful and aware, giving them voice and choice over their options, providing psychoeducation around the way that language impacts trauma in the brain developmentally, right? Those are all parts of me being a culturally competent clinician who's also following the code of ethics.
Yeah.
So I'm really glad you brought that up, and I'm so glad that you're seemingly really aware of some of how to, you know, strategies and opportunities for applying some of what you're learning here into other languages, cultures, spaces.
Yeah. Because even for me, a lot of the words that are used, it's not necessarily like, I'm not even sure what trauma is translated, you know? So it's like making sure that those diagnoses even and all these things are like even explainable, you know?
Yeah,
So,
that's a good point. And maybe it's more about you understanding them and being able to explain how it works in the body, even if it's not
rather than having a specific word. Yeah.
Yeah.
Right.
Yeah.
Yeah.
Good. Well, good work today. I love all of what you named in terms of your strategies. I will also throw out, as someone who's been doing trauma counseling for a while, self-care, really important, knowing when we're doing too much. I'm doing my dissertation now on vicarious trauma. And so trying to be really aware that as educators in this field, for Dr. McCormick and myself, that we're making sure that we're giving you all the tools to avoid vicarious trauma and be able to handle working with clients who bring a lot of hard stuff, but doing it in healthy ways. I loved, Victor, your analogy of the light, of making sure that we're staying positive, and that if we end up kind of going into the darkness with the client, we have to be aware and like shut that down and work on ourselves immediately so that we can make sure that we're maintaining our healthy selves. So I wish that for you all.
Thank you so much.
Yeah, thanks for the engaging and enlightening conversation with you all. And for those of you in other places, for staying up late. I think it's past midnight now for Victor.
Oh, wow.
Any final thoughts, Dr. McCormick, before we let our folks go?
No, thank you all so much for being here today. Just a reminder that part 2 is just writing a couple paragraphs about your key takeaways for today. And then that is due by Sunday at 11:59 Central Time this week.
Okay.
Perfect. Thank you.
Yeah, it was
Thank
good
you
to
all
see
so
all.
much.
You're always welcome to reach out. I think you have my contact information in Canvas. So if you have any questions or thoughts, always here to be a support. But it was lovely speaking with you.